Welcome to Harm Reduction, Can't Get No Satisfaction, a title bequested to us by our inspirational friend Anya Sarang. I'm Naomi Berkshine. I'm the Deputy Director of Harm Reduction International, and I'll be your co-chair for the session, along with Janine Waldschut, who's the Director of Programs at A Few Network International. When I looked at the abstracts put together for this session, I was really excited because it demonstrates it's a really great reflection of where we are in harm reduction at the moment. You know, if we're sitting in this room today, we all know it's about more than needles and syringes. It's about more than opiate substitution therapy. What we're seeking to do with our new ambition for harm reduction is to make it person-centered, to make it responsive, to make it about the people at the heart of it, and to follow the leadership of people who use drugs in delivering services that save lives. And with this ambition to do better, we have an incredible array of panelists. Got Eberhard Schatz from the coordinator of Correlation, the European Network of Social Inclusion and Health, followed by Nebatov Ilham from the NGO Kujan in Tajikistan. Sun Tun from Myanmar is a public health professional focused on epidemiology and biostatistics. Edward Mbizo Sibanda oversees the key populations portfolio within the Right to Care program at the Global Fund in South Africa. And Abdur Rahim Rijay is the program director of the Bridge program in Afghanistan, the Manara representative of Input, and a member of the Drug Civil Society group. Before I pass it over to Eberhard to start, it's probably worth remarking that as our ambitions grow and we expect more from our harm reduction programs, more from the leadership, more from the community of people who use drugs, it's worth remarking that, you know, last week Michelle Sidibe said that there's a 20% shortfall in funding for the HIV response. Harm Reduction International has published new research this week that indicates for the harm reduction component of that, we're at close to 90% shortfall. So as we become more and more ambitious in what we hope to achieve from harm reduction, we need to demand more of our funders, and we need to get much more strategic about how we fund our response in order to have a holistic, full-spectrum response for people who use drugs. Thanks, Eberhard.
Okay, yes, good morning and thank you to having me here. I didn't had a long travel because I work in Amsterdam for a service provider here, and I'm one of the coordinators indeed of the newly renewed correlation network, which is now called the European Harm Reduction Network. So I want to talk to you about drug consumption rooms, but then in the relation how those facilities address HCV, because we are on the AIDS conference and it is not a general presentation on what are drug consumption rooms. However, you find a lot of materials and also extended surveys about that on our website. So today I speak about how drug consumption rooms address HCV. And it is in close collaboration with Sydney Medically Supervised Injection Center. They call it like that, and we in Europe usually call these facilities drug consumption rooms for different reasons. The Sydney consumption room, however, is the first one in the southern hemisphere, in the Anglo-Saxon world, and it was already established in 2001. And as all drug consumption rooms, they aim to reduce death and injury from drug overdose and reduce harm associated with injecting drug use. They have an amazing crowd of people visiting the facilities with more than 1 million visits and more than 16,000 registered clients. In all those years, they not had at all one fatal overdose. And of course, they could refer a lot of people to other health-related services, so more than 30,000, and they managed to handle overdoses in more than 7,500 cases. So really, that is a very impressive numbers. Our drug consumption rooms, which are not run by our correlation network, but correlation network is a part of is the international unit of the Rainbow Group in Amsterdam. We run 4 drug consumption rooms, and I will talk a little bit about that later. However, the correlation network was launched in 2004. We have 4 major pillars: networking, monitoring from the viewpoint of civil society, and capacity building advocacy, and we do a lot of work on hepatitis C, overdose prevention, drug consumption rooms, and new drug trends, and civil society involvement in drug policy as an overall issue is very important to us. At the same time, we also host the International Network of Drug Consumption Rooms. That is an initiative to bring all these rooms together. Currently, we have around, and this is an increasing number, luckily, because mostly in Canada, we saw a lot of openings of the facilities. However, when we did our surveys, we addressed 91 rooms, and the network is obviously there to sharing best practices, to work together on common guidelines, to to have exchange visits, and so on. So everything around drug consumption rooms you can find also on the specific website of the international network. When it comes to drug consumption rooms and hepatitis C, we all know that hepatitis C is a major problem for people who use drugs, and the prevalence rates are extremely high, with up to 80–90% also in European countries. There is almost no research on specific HCV prevention treatment in those DCRs. However, what we found, for example, in Germany, was a prevalence of 63% under visitors on drug consumption rooms, and, for example, 43% in Spain. Both countries have a relevant number of drug consumption rooms. And as we know, at the same time, we have a dramatically improved cure opportunities for HCV with the new direct-acting antiviral agents, the DAAs. At the same time, we have a lot of improved technologies, testing methods, to really be able to test people in low threshold centers, in drug consumption rooms, in harm reduction service, and so on, and even to treat them. If regulations and the health system allows, you could easily treat people in low threshold facilities. So that makes it, from our point of view, so interesting to look into what drug consumption rooms could do in this respect. So our questions in regard of that was, what is the range of HCV services currently offered at DCRs? What are the operational capacities to do so? What are the factors associated with HCV service in DCRs? And what are the needs and resources requirements which would be needed to improve or increase those designs? So we asked the DCR managers for a 30-minute questionnaire. No question was obligatory, but if less than 50% of answers were missing, we excluded them. And that is the overview. Once again, here you see the countries with the most rooms, with the Netherlands, Switzerland, Germany, and Spain, which have, for example, in Spain, you have 15 rooms, but they are concentrated in the Catalan area and in Bilbao, so you can't speak at all over coverage in the country. Even in Germany, you have only a couple of parts which are covered by consumption rooms, and the Netherlands have a quite balanced coverage, you could say, and also Switzerland. And the remaining countries, unfortunately, only have a few of those. So Australia, Canada in those years had only one. I think there are now more than 10, so that is really an absolutely very positive development in that regard. In France, we have 2, considering that France was always a very conservative country. At least that is a landmark, and at least that is something that gives a message, but 2, of course, is not fit at all to the needs. Denmark has a quite good number with 6. Norway and Luxembourg completes the picture. So we looked into how these rooms, the drug consumption rooms, are organized. Most of them are run by NGOs or by local or central government. For example, in Amsterdam, we also have drug consumption rooms with the municipal health service. A couple of them are private, and also a church was involved. Most of the rooms are co-located with other services. That means that they are in a cascade of care of integrated in services, but we also have a couple of those standing alone facilities, and very important also a couple of mobile services, which is really in a way cost effective. You can reach neighborhoods where other ways no facility could be established. So that is a very important measure to have. And in average, the size of those rooms, it's about 12 places, and let's skip this sheet. We also asked who is included in DCR staff. So we see that 80% of DCR staff have a nurse, they have social workers, and to less extent, they have a medical doctor, health educators, and at least 21% have also paid peers in a paid position, which we think is a very effective and useful tool to have, and we would like to see that this number is increasing in the future. What services are provided on-site by drug consumption rooms? So almost all are referred to care and other treatment facilities. So also here you can see drug consumption room is not a self-standing measure, but it is an integrated part of harm reduction and other treatment services. Obviously, they distribute needles also for takeaway. They provide condoms, and they have overdose management, but of course, it is very obvious that they do having this task. So HIV testing is carried out by more than half of them, outpatient counseling, mental health care, take-home naloxone provision, and so on. And in case this takes not place on the spot, at least they can refer to elsewhere, which is the second best opportunity, but it is one. So what are in regard of HCV services they are involved in? So 94% of the rooms offer HCV-related education. That is basically safe use education about transmission routes, about testing symptoms, treatment options, and they do that by brochures, pamphlets, individual client consultation, posters, and to less extent to digital resources, educational campaigns, or also group education sessions. But what you can see, most of those have awareness on HCV, which is very effective in order to tackle this disease. What they do on HCV and support services. So most of the consumptions are able to refer to other services for HCV treatment or also planning to event. They have on-the-spot disease self-management support, speaking about to counsel and to speak to people about healthy diets and obesity and so on and so on. And also a few of those have liver health monitoring assessments, which is already a quite advanced measure in this area. In regard of the new treatment options, this is not at all developed right now. We found 2 rooms who on-site could offer HCV treatments with the new DAAs. It is really very important that we can see it is possible, but in the future we would really argue and advocate for to increase that number dramatically. So what factors associated with HCV testing on-site? What we found out is that if DCRs provide HCV testing on-site, they obviously were significantly more likely also to provide HIV testing and HVB vaccination. So that is with a factor of 44 that HIV testing is offered in case of testing anyway. And if DCRs employ a nurse, it is also very obvious that they also provide other medical services. This is really significant, but for me also not really a surprising outcome. And the same takes place with if people have HCV disease management, they employ a medical doctor or they provide opioid treatment. So all this is linked with each other, and again that says that drug consumption rooms can provide a range of health services and not only facilitates safe injection. What would be needed to increase these capacities? So the most answers were that they would employ additional medical staff and spend more time on training, which obviously and is a very important measure in order to increase the capacity and finally the service provision. They would also fund additional materials, and they would employ peer support workers or improve the referral pathways to specialists. Now, and to finalize my presentation, I would go a little bit more in to demonstrate the practical impact and to demonstrate the case study. And our colleagues from Sydney provided me with these sheets. So, as you might know, Australia have a really amazing HCV elimination program. They will spend $1 billion Australian dollars in the next 4 years, or they started in 2016, so it's 3 years left, on HCV treatment with a barrier-free treatment also for people who use drugs. And in case they include more people and costs would rising, pharma industry committed themselves to cover these costs. So that is really an amazing concept. At the same time, as I said before, the drug consumption rooms, these 2,000 people a year, which are not in contact with, I would avoid to speak about hard to reach, but which are not in contact with regular health services. That means that the colleagues in Sydney need to refer people to other clinics. They have reliable collaborations on that. However, it is not that they can do that in their own facility, and that is a disadvantage. So they are allowed to administer particular treatment options, but not for HCVs. So they have to mediate them to this clinic, and this appears still is a problem for many people. That still is a problem to go to another spot, and there's quite a lot of dropout on that. So that needed to be changed, but let me explain you one case that is a man in the 30s with a long history of injecting and street-based homelessness, over 15 years HCV positive, and the experience showed that the adherence to any medical treatment options is very low. At the same time, this person has an uncontrolled epilepsy with 2 to 3 times attacks a week. So that here again, it was a big problem that the adherence was very low. So the only service he engaged was the drug consumption rooms, and which he attends 2 or 3 times a day. So it should be the best solution anyway to do everything in terms of medication in this facility. So they managed in first instance to get the epilepsy medication to the room, and for him to bring him for him to self-administer this medication. And they also linked him to HCV testing. So then they could make an agreement with the pharmacy and with the health authorities that also the DAA treatment was included in this package, specifically arranged for this person. And since then, the results are very, very positive, and he has cleared HCV after 3 months, and he also was able to follow his obligations and to follow his treatment. So that is really a very impressive example how it would work and how we would overcome all the barriers in regard of HCV treatment in low threshold centers. And that is something what we really want to see much more in regard of harm reduction and hepatitis. Thank you.
We're going to take questions at the end. So our next speaker, I'd like to welcome Ilham to the stand.
Добрый день, уважаемые дамы и господа. Меня зовут Ильхам Нематов. Представляю общественную организацию Худжан, Республика Таджикистан, Сагдийская область, город Худжан. Наша организация в 2017 году при поддержке Few International реализовала проект, который был направлен на выявление факторов, влияющих на удержание пациентов в программе заместительной терапии на базе сайта города Худжанда. И вашему вниманию предоставляется краткая презентация по итогам данного исследования. Республика Таджикистан, как и большинство стран Центральной Азии, в последние десятилетия сталкивается с большими проблемами с незаконным оборотом наркотиков, влияющих на здоровье людей и общества в целом. Несмотря на то, что программа реализовывается уже более 5 лет и как бы расширяется количество сайтов, предоставляющих данную услугу в нашей стране, количество людей, охваченных данной программой, как бы не соответствует ожиданиям. По последним данным, в 2017 году официальное количество людей, охваченных данной программой, составляет 714 человек, что в процентном соотношении составляет около 10% от официальных людей, зарегистрированных с проблемами наркозависимости, или 3% от оценочного количества людей, употребляющих инъекционные наркотики. Я как бы здесь еще хотел к этому слайду добавить, что как бы на страновом уровне данная программа имеет хорошую, очень сильную поддержку, и данная программа включена в государственную национальную программу противодействия эпидемии ВИЧ-СПИД, где предусмотрено увеличение количества людей, охваченных программой заместительной терапии, до 20% от оценочного количества, или же 460 человек, с ежегодным долевым финансированием со стороны государства. Высокий уровень утечки пациентов нашего сайта как бы вызывает опасения не только сообщества и гражданского сектора. И есть опасения, что данную программу закроют из-за как бы ее неэффективности. И по официальным данным наркологической службы нашей, причин утечки несколько. И здесь я бы хотел привести цифры официальные, что попадание в места лишения свободы 38 человек, исключены за нарушение правил программы 71 человек, прервали терапию по собственному желанию 53 человека и умерли 12 человек. Я бы к этому слайду хотел бы добавить, что несмотря на то, что организация, которую я представляю, молодая, это реализация данного исследования, это как бы уникальный опыт, полученный нашей организацией. И здесь также хотел бы отметить, что без вклада сообщества активистов, волонтеров нашей организации, как бы реализация данного исследования не могла бы быть такой эффективной. Здесь на слайде приводится характеристика респондентов. Возрастная группа от 34 лет до 46. Средний возраст составляет 40 лет. Разбивка по половой принадлежности 6 женщин и 12 мужчин. Здесь как бы был учтен гендерный баланс. Среднее пребывание в программе респондентов 3 года. Во время проведения интервью 3 участников, респондентов являлись пациентами программы. 15 человек вышли по различным причинам, это 83%. 4 респондента, у 4 респондентов был положительный статус ВИЧ. 5 людей, это 28%, имели положительный статус гепатита С. Здесь приводятся результаты. Я бы перед озвучиванием негативных сторон программы хотел бы как бы еще озвучить положительные стороны данной программы. Со стороны респондентов были положительные высказывания о самой программе, как стабилизация жизни, возможность воздержаться от потребления нелегальных наркотиков, рисков и опасений, связанных вовлечения в рынок нелегальных наркотиков. Во время пребывания программы они отмечали то, что как бы они уделяют больше внимания своему здоровью, близкому окружению, социальной сети, которые их окружают. Кроме того, были высказывания врачей наркологов, которые непосредственно предоставляют данную услугу, положительные высказывания о том, что здесь как бы приводится дословно цитата врача: до начала реализации программы заместительной терапии время тратишь, силы, детоксикация, а все равно бывает случай рецидива и срывов. И когда он получает метадон, у него свободное время, трудоустроился, вид получше, поправляться стали. Все это стабильность, контролируемая доза, поэтому метадонная терапия мне понравилась больше, чем детокс. И дальше как бы показываются результаты самого исследования. Ожидание того, что программа поможет человеку избавиться от наркозависимости, вполне оправданно и понятно, потому что как бы в представлении, укоренившемся представлении, целями любой терапевтической программы является полное избавление от зависимости. Именно зависимость представляет собой основное бремя, от которого хотелось бы избавиться, обрести контроль за собственной жизнью. Поэтому многие респонденты были удивлены, когда осознали, что программа не ставит перед собой целью полное прекращение или избавление от зависимости, а предлагает длительную терапевтическую программу с соблюдением определенных условий пребывания в самой программе. И когда люди находились в самой программе и в течение длительного времени, и вот это ощущение превращалось в то, что людей обманывают, некая иллюзия обмана появлялась у пациентов программы. Повышение дозы воспринималось врачами как способ снижения тяги и влечения к другим психоактивным веществам и как бы меры предосторожности, профилактики передозировок. Однако эта инициатива врачей воспринималась со стороны пациентов как неоправданные действия, которые могли как бы негативно сказываться на их самоощущении, да, снижалась доза и другие как бы терапевтические штучки. И здесь большинство, как бы в ходе проведения исследования мы пришли к выводу, что отсутствует некий коммуникационный мост между врачом и пациентом, нет такого единого уровня, да, общения между пациентом и врачом. Многие респонденты, у которых была практика смешивания метадона с другими психоактивными веществами, и которые как бы попадались на этом, было естественное желание людей, которые находятся в программе, получить некий дополнительный кайф, да, некое другое удовольствие от самой программы. При этом часто в практике случается, что контракт, который подписывается между пациентом и администрацией сайта, он со стороны пациентов как бы читается вслепую. Или пациенты приходят с ожиданием того, что я буду здесь где-то 2 недели, месяц, 2, 3 или месяца, и потом уйду из программы. Ощущение потери контроля над своей жизнью и продолжающейся зависимости было в первую очередь связано с требованием ежедневного посещения сайта. Подобное требование влечет за собой большие сложности в разрешении проблем социальной жизни пациента, мешает ресоциализации, трудоустройству, подчиняет жизнь пациента условиям работы сайта и мешает формированию здоровых навыков жизни. Кроме того, ежедневное посещение сайта влечет за собой и экономические траты, да, ежедневные траты на дорогу, переезд и прочее. Здесь на слайде приведены рекомендации, и первые 2 рекомендации направлены на увеличение охвата программы большего количества потенциальных участников программы и для популяризации самой программы. Если как бы эти рекомендации примутся во внимание и будут приняты, то мы думаем, что эта услуга станет более такой низкопороговой и привлекательной с точки зрения сообщества. Вторые две рекомендации направлены на создание того коммуникационного моста, о котором была речь, что будет единый уровень общения между врачом и пациентом, и будут некие механизмы получения обратной связи об эффективности самой программы. Последние две рекомендации направлены на то, чтобы достичь того качественного скрининга, фильтра, да, перед первым контактом с потенциальным участником программы. И кроме того, информирование, да, на должном уровне пациента о условиях пребывания программы и правилах программы. И всего, что касается самой программы в целом. На этом у меня все. Спасибо за внимание.
Thank you so much, Ilham. It strikes me as we move from Eberhard's presentation in a high-resource setting to Tajikistan in a low-resource setting, that we see both programs shifting and trying their best to improve the way they're responding to the actual needs of the people that are coming for services. You know, the complexities of adherence when you're looking at just one part of a person's life seems to be highly unrealistic, and it's heartening that we have harm reduction services that are looking at the whole person. Sun Tun from Myanmar will be speaking next, and continuing the discussion on methadone programs.
Good morning, all. I'm Santun from Myanmar, and I would like to present about the relation of the methadone dose and illicit drug use ingestion among the methadone clients in Myanmar. I would like to declare that I have no conflict of interest for this study. The background is that there are people who inject drugs in Myanmar. They have their HIV prevalence rate is highest among the key population, which is the 28.5%. And then the female sex workers have their 14.6%, and men who sex with men has their 11.6%. National HIV prevalence more than 15 years older have that stabilized below 1%. For the PWID in Myanmar, some area has the higher HIV prevalence, like in Waimor in Kachin State has the published data shows the 47% of HIV prevalence. So to address those harm reduction activities is like National Drug Abuse Prevention and Control Program has the programmatic support and financial support to address those interventions work with the opioid substitution therapy with methadone. In Myanmar is that the national program currently supported with the more than 13,000 of the PWID are on methadone, which is the 16% of the total 83,000 PWID in Myanmar. So the study objective is that we are checking the relationship with the methadone dose and frequency of illicit drug use and risky ingestion behavior among the methadone clients. This study is the ethical review is granted by the Department of Medical Research in Myanmar and University of Science in Malaysia. So the study design is the cross-sectional study, and then we are recruited methadone clients from the 5 cities where the methadone services deliver in the country of 5 states and regions, which is the Yangon, Mandalay, Shan, Sakai, and Kachin State. The study conducted in the May to July 2017. So the study participants are the 42 participants each from each site with at least 6 months on the methadone. And we also asked the participants, for those who agree for the urine examination for the illicit drug detections, we are examining the morphine, cannabis, methamphetamine, amphetamine, and benzodiazepine. These are the participants' characteristics. Reported HIV status is 37%. Hepatitis C status is 48%, and hepatitis B is 8%. The average methadone dose, what they are reported is 83 milligram. the national recommended dose is 80 milligrams, so that those who are lower than the national recommended dose is 63%, and those more than 80 milligrams is 37%. Reported heroin injection within 30 days is 55%, and illicit drug finding in the urine is one or more drugs in the urine is 74%. So we analyzed that those response with the regression analysis to see whether the dose is effective on the outcome of illicit drugs in the urine. And we also take into consideration of the age, gender, body mass index, and duration of the methadone. And we also analyze by the different HIV status. For the injection rate difference among the different methadone doses, we analyzed the Kaplan-Meier analysis. So the high dose of methadone, more than 80 milligrams, is associated with the decreased cannabis in the urine and decreased morphine findings in the urine, especially for the HIV-negative individual. And reduced heroin injection frequency is differ among the no injection group and more than 7 injection group. The high dose is significant. The methadone dose increase is also associated with the increased benzodiazepine use in the urine. And high dose is also associated with the currently taking antiretroviral therapy. Among the 37% of the HIV reported cases, 92% is on the ART. So for the regression analysis, increased methadone dose in this case showed us that when we are increasing the 15.7 unit of the methadone, that is when cases of the morphine will be decreased findings in the urine, which is significant among the HIV-negative individual. This is also applicable among the HIV-positive individual. When we increase the 34 units of the methadone, that caused the 1 unit decrease of the morphine usage among the HIV-positive individual. Those who are the higher dose is linked with the longer durations on the methadone program. So this graph shows that we are also estimating the constructing to assess the probability of injections over the multiple dose point. We can see here the red line is the HIV-positive individual and the blue line is HIV-negative individual. Here, the methadone dose is plotted on the x-axis and then the heroin injection within 30 days is plotted at the y-axis. When we increasing the dose, and then the heroin injection within 30 days is going down. So this is quite significant with the different HIV status. And we can see here, 13% of the HIV-negative individual, regardless of the dose, they are still injecting. And same for the HIV-positive individual, 8% of the clients are still injecting regardless of the dose. So to reduce at least 50% of the heroin injections within 30 days, we can see here, this is the estimated dose, 65 milligram is necessary. So based on the analysis, to reduce 50% of the heroin injections within 30 days, 65 milligram dose is necessary among the HIV-negative individual. And for the HIV-positive individual, is that to reduce 50% of the heroin injection, we need 140 milligrams of the methadone dose is necessary. So among the different HIV status, we also check for the injection rate difference with a different methadone dose. For more than 80 milligram high dose, which caused the 4 times reduction of the injection of heroin, we also confirm with the morphines in the urine. So we can see here that the 3% of the injection prevalence, injection incidence we can see here among the low dose, and then the among 3% of the injection incidence can see among the high dose of methadone clients, and 12% of the injection incidence can see in the low dose. This is statistically significant as well. Among the HIV-positive clients, high dose also reduced the 2.6 times of the injections, and it also statistically significant. So I would like to conclude that in the Kaplan-Meier findings, to reduce the 50% of the heroin injection, we need more than 65 milligrams of the methadone for the HIV-negative clients, and more than 140 milligrams for the methadone for the HIV-positive clients. So high methadone dose is recommended for the reduction of the heroin injections and other illicit drug use. I would like to thank to all the supporters for accomplishment of this research, and thank you very much for your kind attention. Thank you.
Thank you for that very interesting presentation. Edward is up next. Edward's been working with key populations in South Africa for more than 10 years.
Good afternoon, colleagues. The title of my presentation today is Reducing Harm Caused by Drugs, HIV Prevention Among People Who Inject Drugs in South Africa. So in terms of introduction and background, Right to Care was awarded a grant in 2016 by the Global Fund for AIDS, TB, and malaria to support partner organizations to roll out prevention programs for people who inject drugs. And in this instance, we are supporting two partner organizations, that is Anova Health Institute and TB HIV Care. And I would like to acknowledge representatives of those organizations who provided data for this presentation. They are in the house. So the program basically aims to reduce the number of new HIV infections as well as the further spread of HIV through the provision of a UN and WHO recommended prevention package of services. But in that package of service, which is recommended by WHO, South African programming currently doesn't factor in hepatitis C, which is Hep C, like my other presenters were talking about. So drug use in South Africa is documented, and there are a number of studies that have been done. And in terms of modeling studies, it has been estimated that South Africa has got around 67,000 people who inject drugs. The HIV epidemic in South Africa is also driven to some extent by people who use drugs. So in a study that was conducted in 2014 by Andrew Scheiber and others, it was noted that 1 in 5 people who inject drugs were living with HIV, a quarter shared needles, a quarter also engaged in sex work, and half used the condom the last time that they had sex. And this was a sample of around 450 respondents. The other issue is within the drug use in South Africa is around co-infection. We have noticed that there's high prevalence rates, HCV, which is your hepatitis C, and the rates, we've got something like 45%. And this was contained in a study by TB HIV Care, which was conducted in 2016. So in terms of location and implementing partners, from that map, you can actually see that most of drug use is concentrated within the coastal areas of South Africa, where TB HIV Care is actually rolling out services in 3 metropolitan cities, which is Cape Town over there, as well as Port Elizabeth in that district, as well as Durban, which is in eThekwini in the east. And then inland, we've got city of Joburg, which is under Anova Health Institute. So in terms of designed intervention, the program is basically utilizing the combination prevention model, whereby a number of components are brought to the fore in an integrated manner. So the program is actually factoring in your biomedical interventions, your structural interventions, as well as behavioral interventions. But at the center of all this is the community. That is, you can't do anything for people who inject drugs without them being part and parcel of the program. So the program actually prioritizes empowering the community of people who inject drugs to be able to roll out services to be part of the peer navigation, to also be peer educators, and also to be involved in the design and mapping of new areas. And then when it comes to biomedical interventions, it's basically around HTS, or your HIV testing services, as well as ART initiation, as well as medically assisted therapy, which is your opioid substitution therapy. And then when it comes to structural interventions, I would like to mention that in South Africa, drug use is still criminalized. So it is an offense to be found in possession of what they call drug paraphernalia. So if you are found with needles and syringes, you'll be arrested. So now the program is also trying to engage relevant stakeholders, such as your law enforcement, the Department of Justice, and all other stakeholders, to be able to try and influence policy and come up with policies that do not inhibit access to health. So out of all this, we realize that our partner organizations, they are responsible for the oversight in terms of monitoring or scaling up of the program. So what have we achieved up until 30th of May 2018? Like the program, I said, it started off in 2016. More specifically, work on the ground started in October. So there are 3 key indicators that we are tracking as a program. So the first indicator relates to HIV, the second indicator relates to OST, and the third indicator relates to the distribution of needles and syringes. So in terms of HIV, the program sets out to reach out to clients with a comprehensive package of prevention package, and in this instance, we have managed to reach 3,502 clients. And in terms of people who tested for HIV, we managed to test 3,292. And of importance is that a 19% positivity rate was actually was established in the program. So in terms of opioid substitution therapy, there are 2 sites, one in Johannesburg and the other one in Cape Town, that is rolling out OST. And we are looking at around 100 clients to be on OST. So, but currently we've initiated 119 clients, and for you to be recorded as being on OST, you need to be on it for at least 6 months, because this is a long-term or maintenance therapy. So out of the 119, we currently have got 31 who have managed to be on the treatment program for at least 6 months. We also have a number of clients who have missed continuous doses of their medication, so we regard them as being lost to follow up, and we currently have got 38 of those. So if we look at the combined site data, the retention rate is around 68%, which is more or less in line with the global benchmarks. So in terms of needles and syringes, we have distributed close to 1 million needles and syringes. So the key issue here is around access instead of inhibiting. So if you want to have access to needles and syringes, you need to be able to get them. So I'll just go down briefly to show you the cascades in terms of our HCT yield per district. Like I said, the program is in 4 districts, which is the city of Johannesburg, city of Durban, city of Cape Town, and Port Elizabeth, which is the Nelson Mandela Bay Metro. So maybe what you can see there is that most of our clientele is coming from the city of Johannesburg, where around 1,634 clients were reached and 1,063 tested, and out of that, 500 were HIV positive. So the HIV positivity rate there is around 47%, close to 50%. But if you look at, for example, city of Cape Town, they actually tested around 997 clients, and out of those, 36 clients were positive for HIV, which is basically 4% positivity rate. So if you look at the HIV prevalence within these areas, they also follow, in a way, the national trends. in terms of provincial prevalence rates. So Western Cape, where City of Cape Town is located, is basically the lowest in terms of prevalence rates in the country. And Johannesburg, for example, it's a commercial hub, which is a hub of activity, and that's why you see the numbers are higher there. But in terms of overall positivity rate, like I mentioned earlier, it's around 19%. So if we look at the overall OST cascade, our partners started rolling out OST in October of 2017, and currently 119 clients have been initiated, and most of those that are initiated are in City of Cape Town with 75, and then Joburg is initiated 44 clients. So in terms of numbers who are currently on methadone, we've got a total of 81 clients who are on methadone, and 55 are in the Cape Town site, and 26 are in City of Johannesburg. But in terms of numbers that have been on OST for at least 6 months, we've got 31 clients who are in City of Cape Town. And in terms of lost to follow up, about 38 clients have been lost to follow up, and you can see that in terms of percentage, Anova Health Institute has lost around 41% of the clientele that they initiated. So there's quite an issue there around adherence. So what are some of the lessons that we have derived from the program? So the program basically also confirms some of the previous studies' positivity rates, which is around 20%. We have also learned that if you involve the target community within the program, it will be easier to roll out your interventions. And then the other issue that we have also established within the program is the issue of adherence to OST. The reason that maybe we're losing clientele is because we don't have much of psychosocial support within the program. So this is something that we are actually advocating for, to get additional psychosocial support in the program to enhance adherence. So in terms of all the clients that tested positive for HIV, they were all referred for onward management, that is for enrollment on ART and adherence support and all that. But due to interest of time, I couldn't go into that cascade, but they are being managed. I also mentioned that around 45% of our clients are HCV positive, so that actually calls for the need to involve HCV programming within the PWID. So it could also act as an advocacy tool as well for us to ensure that within the next rounds or other stakeholders can actually come on board to ensure that hepatitis C is actually factored into programming in South Africa. So in conclusion, the results from our program show an increased access to HIV prevention services and early enrollment in HIV care and treatment, including medically assisted therapy, which is your OST. In a nutshell, the program has addressed some of the accessibility, applicability, appropriateness, and availability challenges that threaten the health needs of people who inject drugs in South Africa. I thank you.
Thank you, Edward. And as I ask Abdur to join, Abdur will sit and speak. But it's worth remarking that there's such a focus on hepatitis C across the presentations today. I think that really is a step forward for us at this AIDS conference, to see that focus across harm reduction service provision. Edward also, it's quite shocking, the stark difference in retention and adherence to OST programs between the different presenters, and I was happy to also see Edward remark on peer delivery, which is a very nice segue to what Abdur is going to be talking about today. As I said, Abdur is the Program Director of Bridge in Afghanistan and the Manara representative of Input. Thanks.
Hello, good afternoon. Thank you for inviting me to speak at this conference. I would like to thank the International AIDS Society for awarding me the scholarship so I can share with you the voice of people who use drugs and other key population from Afghanistan. Vision of a bridge. My presentation draws on key population consultation that took place in Kabul last month. People who use drugs, sex workers, PLHIV, and MSM come together by respecting each other and differences. Key population in Afghanistan need to bring their voice together so they can be heard in a system that makes so little space for key population. Please don't take photo of the photo of my presentation, as we need to protect the safety of people who come to this event. Bridge was set up by people who use drugs. We have two main rules to deliver peer harm reduction service to drug users and represent drug users in the policy and planning system. Bridge milestone. Bridge supported the UN and the Afghan Ministry of Public Health to consult our 400 key population in support of the Global Fund HIV application from Afghanistan. The Global Fund technical review panel congratulated Bridge for the quality of community consultation. It was key to Afghanistan getting this National Global Fund grant. Bridge was promised support as a sub-recipient. However, the agreed funding option was not successful, so Bridge has been left with very little resource. With the support of COAC, Technical Support Agency, Bridge has trained and developed a team of peer workers who are drug users. First, they work as peer researchers to deliver the community consultation. Then we trained them to deliver harm reduction intervention. We have approached for a short period with a small grant, and we have helped out when other harm reduction providers have not been successful. The Afghan harm reduction NGOs provide very poor services for people who use drugs. The NGO outreach workers are fearful to work in the middle of the open drug scene. They limit how many syringes are given to injecting drug users, and they provide only basic services. Bridge peer workers have addressed the terrible injecting injuries that led to drug users to lose their limbs and lives for no reason. Bridge peer workers delivered 1,300 wound care intervention in 3 months before having to end the service due to lack of funds. Sex workers. In the past, sex workers have run a successful peer education and condom distribution program. However, since this program ended, female sex workers have had no voice and no self-organization. They have decided to mobilize with the Bridge, and they are led by a great peer leader called Shafiqa. Non-drug using sex workers earn money and therefore can make a choice. Drug-using sex workers face a bigger risk and exposed to violence. The sex workers have mobilized together with Bridge, but they have no resource to work with. They want to run their own services, educating and supporting sex workers. They want to share their voice in the planning and review of the HIV response. HIV. People living with HIV are represented by the NGO running their clinic. Bridge has funding to help coordinate the HIV network, but we are expected to pay for the event from our own pocket and then to claim the money back. Afterward, they tell us that this show community separate. We say that is unfair when we have no money in our pocket to pay our for the event in the first place. Bridge have HIV coordinators in each region who are ready to build a self-help group, but they need resources. And Idris is the HIV coordinator. Bridge is the only person who stands in the front of the media. He said, I am HIV positive. After that, he loses family and wife. MSM. In the first community consultation was also engaged MSM. This started a decision between Bridge and our MSM peers, and first trans person we have met in Afghanistan. MSM and trans come together to the key population consultation, and there was agreement that we all need to work together. We all face the same problem of services, service providers speaking for us, and officials only engage us in a tokenistic way. MSM in Afghanistan face danger and violence under Sharia law. Their lives are very vulnerable even from a young age because of the dancing boy culture in Afghanistan. We are ready. Bridge is ready to go. Our team of drug users, sex workers, HIV, MSM, and trans are standing by with great courage. Please don't leave us for another 4 years with promise of funding that don't arrive. We cannot act as a community watchdog without resources. You are asking us to put our life at risk. We will do this because we love and care for our community. However, we need to promise international law and care. Thank you.
Thank you, Abdur, and it's very impressive to hear what you say and also speaking out for what you need. I think if we hear all these stories for all around the world, it is immensely powerful, but also immensely sad that we can see what works and that we can also see what doesn't work. But not because it cannot work, but since we don't do it or we don't have the resources. And since we see the comprehensiveness of all the services that is needed to be effective, and that can only be effective if there is comprehensiveness, we need to also consider that there are people that are not injecting, but that are using non-injectable drugs, but that also have similar needs, sometimes because of HIV, but also because of all the needs that people have. So I want to thank the panels very much for sharing all their expertise. And I want to invite you to come to the floor if there are any questions for information or something that you want to put forward for discussion. Here, there's a mic. So, okay. No. Yes, please.
Hello, everyone. My name is Ernst. I'm with MDM. Just two small remarks. I had the pleasure to work with Rahim in the past, and I'm super happy to have you here. And bravo, Rahim, because it's incredible to collect sex workers, MSM, key populations all together in a super difficult context in Afghanistan. Fantastic. The other remark, I've also had the pleasure to work in Myanmar on MMT. So I'm very happy to see the presentation and to see the international recommendations of WHO being confirmed with dosage. But I think it's also important to mention that dosage is a communication between a medical professional and a client. And sometimes I'm a little bit scared in Myanmar that we go into a direction of one size fits all. You have to give at least 60 or 80 milligrams and then we're settled, but it's not like that. We really have to keep talking, health professionals and clients, and get an interval dose. And for some people that might be 100, it might be 200, but it could also be 20. And I've had a lot of conversations with health professionals that didn't understand the message and they were giving higher doses than needed. So I think it's important that we also share that message with them. Thank you.
You want to give a reaction?
Actually, what we are analyzing based on the participants' profile is that there are something like a minimum, something ranges. That is like a 65 milligrams to the 165 milligrams for the HIV negative individual, and then that is the 50% reduction of the injection. But in the presentations, we can see that the rangings from the 20 milligrams to the 300 milligrams depends on the individual cases. What I'm analyzing is that it is based on the participant's profile, what will be the recommended dose to reduce the 50% of the injections of the heroin. Yes, thank you.
It's also interesting to have this like footage for us to understand what is needed, but it's all small components to do the full programming, and I think it's perfectly said that we deal with people that need a dosage, but depending on their whole situation and depending on many factors and in communication with each other. Thank you.
Thank you for all your presentation. My name is Albert. I'm from Indonesia. I'm really interested with Mr. Suntung's presentation earlier. Maybe my question is also linking to the previous comment. As Mr. Nematov has already mentioned in his presentation about many people who use drugs drop out from their program because they fear about methadone addiction. But contradictory to your presentation, you suggest to increase the dose for methadone to decrease the dose of morphine and also heroin. So what do you think is the best way to convince people who use drugs to take more dose on methadone and to communicate to them without stigmatizing them that they will not just changing their addiction? Thank you.
Thank you. In that point, it's like for the among the HIV positive individual in the presentations, we can see that in the regression analysis, if we increase the dose, and then the clients will be more in the program, it's also find out significantly. In that case, it's like it is linked with the other service delivery as well, but I don't know other panels can also address for the retentions of the program as well.
So I think we could have done better in terms of OST retention, if we had like psychosocial support, for example, that I spoke about. So the reason why we get high numbers, for example, in Cape Town, is because drug use in that particular area, there's a history and it has been there for a while. And actually the clientele were yearning for OST, so they actually wanted to be on OST. So it was a bit easier compared to Johannesburg site, which was for us a new site altogether. So there are a lot of things that we need to explore, and one of them is the psychosocial support.
Hi, good afternoon. I would like to thank very much all the speakers and the chairs of the session. It's been incredibly interesting. My question is to Rahim. Thank you very much for your presentation. I was interested in the way you presented the intersectionality of risks, and especially when you talked about MSM and transgender people and their involvement in sex work. I'm also interested if there were some work done with the bachas regarding drug use and prevalence of drug use, if these young people use drugs a lot, and also what happens with the bachas when they grow up, and are there any programs that like do any work? You said there is a huge rape culture and most of them have been suffering from rape. Is there any work that addresses this gender-based violence also in relation with issues related to drug use? Thank you.
I want to ask my technical advisor, Matt Sotwell. He was working in Afghanistan. He has the picture.
Just to say, the situation with the dancing boys is incredibly challenging. They start off as essentially a form of organised paedophilia, of young boys being taken into marriage ceremonies, and then essentially older men having sex with the young boys. They're then drawn into a culture where they're often taken into prison, and then when they're in prison, they're asked to dance for the prison guards. So there's a constant process where they're being criminalised and exploited, and then used culturally, and then exploited. And they find it just completely contrary. Most of them end up as working as sex workers, and then they face more violence from being sex workers. We didn't see a lot of drug use among the dancing boys. We didn't find very much at all. But it's still a very new area of work.
Thank you.
Hi, Edward Kachai from UCSD. I would like to commend the presenters on the great work that they are doing. My question is for Dr. Tam. There are multiple factors that influence the amount of methadone use in patients with HIV. One of those is drug interactions, because boosted PIs and efavirenz, they both will decrease the levels of methadone, and it looks artificially that they are using higher dosage. Do you know what type of antiretrovirals they were taking, your patients, and whether they were on BID, boosted PIs, and so forth, or integrase inhibitors? Thanks.
So in this analysis, it's like we only take into account of those who are on the ART, because mostly 92% are already on the ART among the methadone clients. So we didn't go in detail to what regimens they are using, but we just only put those who are on ART as take into account for the analysis. But we make sure for all the age, gender, BMI, and then the durations on the methadone was taken into account. But those who are on ART is take into account, because for this drug interaction, that's why the dose is minimum dose is we need higher dose.
Thank you. Palani Narayanan from the Global Fund. Dr. Sundan, thank you very much for your presentation. May I just request, as the first floor speaker said just now, when you present this, to talk about the important need of doctors talking to patients when discussing dosage. That's number one. Number two is the fact that, HIV positive patients require more dosage because of the interactions with the drugs that they take, because some of the drugs causes the increase increase in dosage to happen. So presenting such scientific studies is so critical in Asia. I come from Malaysia, so I know this. It's so critical in Asia, but it needs to be put in context of the implementation challenges that we face. Similarly, we have 30, 40 years or 50 years of results from methadone studies from around the world. We have so much. And so, Edward, I would really recommend that we don't bring down the need for increasing retention as just to psychosocial support. I think there are a number of reasons why people don't retain in services. Number one is the dosage is a problem. We need to increase the dosage. Number two, of course, psychosocial support. And the research shows that it increases retention by about 25 to 30%. Number three is access. Very often, the services are at the wrong time, too far away from the place where drug users need to go. There is heaps of issues of access. Number four is the attitude of staff and people who are providing those services. It needs to be friendly and open. So let's look at all of those issues and look at why in South Africa there is such low retentions of services. I think those things are really important. And Rahim, we hear you. We heard the problems that you're facing with getting funding and with talking to your principal recipients, and would be very happy to continue this discussion with you after this as well. Thank you.
Thank you. I think this will be the last question because of time, and then we have to round up.
Hello, Jean-Luc from Coalition Plus. Thank you for these interesting presentations.
Can you come a little bit closer to the mic?
Yeah, I just have one question. Thank you for these interesting presentations. Can you tell us in the different countries what are the measures to avoid clients selling their methadone afterwards, and if you are able to quantify these practices?
Selling their methadone, so that it gets to the illegal, so that it gets to the illegal market, you mean?
Sorry?
The methadone coming into the illegal market, you mean, by selling?
Yes, in many countries we see clients going to the methadone centers, getting out and selling to other people and using it as a drug instead of substitution.
So in South Africa, methadone, you take it, it's a directly observed treatment. So you take it in front of the clinician. Currently, we don't have take-home doses, for example. But that's something that we are toying around with. With the time, those who have been on the program for a while, we will start putting them on weekend doses, for example, then not just giving everyone to take home. So it's directly observed treatment for us.
Please, yeah. Put on your microphones, please.
Я начну со второго вопроса, да. Несмотря на то, что метадон входит в список основных лекарственных средств, его в Таджикистане в свободном доступе нет. И за все время работы программы не было случаев выноса или проноса метадона за территорию сайта. Это уголовно наказуемо. За это прилагается статья. По первому вопросу я хочу отметить, что программа в таком формате, которая сейчас она существует, она ее спектр услуг очень узкий. Человек приходит туда, получает свою дозу, и нет каких-то терапевтических программ или каких-то досуговых центров на территории сайта, чтобы человек проводил время и восстанавливал изменял свое поведение, да, и чем-то занимался. Со стороны гражданского сектора, то есть специальностных НПО, проводятся группы взаимопомощи, но они нерегулярные, да, и информирование, консультирование по формированию приверженности, но того спектра услуг, который предназначен для пациентов заместительной терапии, его мало, и поэтому есть такая высокая утечка из программы. Спасибо.
Thank you. And the last question, I think it would also be really interesting to visit the harm reduction networking zone and discuss with some people there, since there are also models where people on methadone can come up on recipe, can take it home, and still it is not a big problem that it is sold in the streets. So I think to discuss these kind of models, the harm reduction networking zone would be a perfect spot. There is explanation there. There are experts on this as well. And some of the panelists will be around as well there. Also Eberhard Schatz, that is not here anymore, but was the first speaker. Thank you so much for joining this session. And have a nice day today. And I hope if you have any other questions, please come up and talk to the panelists.